Thank you so much for asking me to speak at this important conference today. My name is Sharon Peacock, and I'm a Professor of Public Health and Microbiology at the University of Cambridge, and I'm also the Director of the COVID-19 Genomics UK Consortium. Now, today I'm going to be talking about tackling antimicrobial resistance in the COVID-19 era and asking the question, what's new? Now, I'm going to just take you through my talk outline. I'm going to cover it in three sections. The first is really looking at whether we can apply new solutions that we've developed during COVID-19 to what I've called an old problem of AMR. There's been rapid scientific progress during the COVID-19 pandemic. And what I'm going to do is pick through the things that I think are relevant to antimicrobial resistance. I'm going to review 8 areas in depth and then mention another 9. The second point is that I'm going to look at the findings of an expert roundtable on COVID-19 and the translation of that science to AMR. Rather than reinventing the wheel, I'm going to go to what that expert group thought about the lessons we could learn from COVID-19 pandemic and actually go through the highlights of that roundtable and their findings. Then I'm going to briefly talk about what are the routes we can take to next steps and action, which after all is what is most important. So on to the first part of my talk, really looking at how we could translate the science of COVID-19 into AMR research. The first port of call has to be vaccines. Now, there's been a massive number of vaccines that have been developed over COVID-19 at a phenomenal pace. Now, if we think about that in relation to AMR, past vaccine attempts against AMR type pathogens, such as Pseudomonas aeruginosa or Klebsiella, have been very challenging. Now, looking at mRNA vaccines, they can be developed quickly and they can come to market quickly. And vaccines against respiratory viruses could also really drive down antibiotic use by treating or preventing respiratory infections. So where could mRNA vaccines be targeted beyond viruses? Now, applying mRNA vaccines to things like bacteria are much more complicated than viruses, I understand. But could they be used to treat, for example, malaria, TB, hepatitis, Staphylococcus aureus, Pseudomonas aeruginosa? Now, this is a discussion for an entire talk, but I'm raising the issue that all of the things that we've learned about vaccines and the pace at which we've taken, for example, thinking about vaccines taking 100 days in the next pandemic, is phenomenal, and we need to embrace that. Now, my next port of call is around diagnostics. We have become really used to home tests now. I didn't really ever imagine a time when I'd be doing a lateral flow test at my kitchen table, or even more extraordinary, my daughter doing it at the kitchen table before she goes off to her educational establishment. They're widely used and accepted. And not only that, when the UK at least went into the COVID-19 pandemic, we had a weak manufacturing base, but that is growing in the UK and elsewhere. Now, can we imagine a world where rapid tests in general practice, where most antibiotics are used and prescribed, could lead to a major reduction in antibiotic prescriptions? And perhaps this diagnostic testing combined with vaccines, could that really drive down antibiotic use? So the question really is, what point of care tests are actually most needed to diagnose infectious diseases in the community? I don't have any simple answers to tell you today, but it'd be really key that we focus our efforts. And we have to remind ourselves that this has to be founded on detection of infection rather than resistance alone. But accepting that, could we use these point of care tests to include detection of resistance in a single test? On then to COVID-19 and clinical trials. Again, we've seen phenomenal clinical trial systems built rapidly for COVID in many parts of the world. So could there be global centers of excellence for trials for AMR vaccines, treatments and preventatives? That could happen in the UK, but it could happen in many other countries where clinical trials have been performed. Now, the UK are a relatively small population and we're quite networked in our healthcare system. So we would create potentially a small but important centre for clinical trials, in addition to networking with people elsewhere. But you'll see on my slides, I've always put questions at the end, really. And this is, how could we develop global priorities and mechanisms to attract and triage those developing new vaccines and therapeutics into clinical trials. Now, the next point of call is surveillance. We've seen a complete turnaround in the way we do surveillance across the world. In the UK, we've had COVID-19 surveillance both for active cases and active disease through immunological surveillance, through the Office for National Statistics Study, or ONS, through REACT, through the ZOE app, and many others. And across the world, the surveillance has really changed in the way we track disease. Now, in the UK, much of the community-based COVID-19 surveillance activity is actually being wound down, but the Office for National Statistics Study continues. So the question here is, how could the current framework or the concepts we've developed be used to lead to a step change in AMR surveillance to provide close to real-time data, which we don't have at the moment, linked to public health interventions, which is what we really need to control the problem. Now, on to sequencing. SARS-CoV-2 has been sequenced at an unprecedented scale and in close to real time, and is really being used to guide public health actions and policy decisions. In the UK alone, more than 2.5 million SARS-CoV-2 genomes have been generated. There's also sustainable genome sequencing networks being developed worldwide. So in the latest WHO report, reporting on their 10-year sequencing strategy for potential and known pandemic pathogens, they indicated that 2/3 of countries, member state countries, had sequencing capability. So how can we make that sustainable and use it for AMR control? So how could sequencing be used in treatment, surveillance, and outbreak investigation relating to AMR? Now, I'd recommend that you watch the outputs from the CEDRIC working group. Now, CEDRIC stands for the Surveillance and Epidemiology of Drug-Resistant Infections Consortium, which sits under the umbrella of the Wellcome, and is currently holding a working group which is split out into a series of 4 working group meetings. They are looking at the use and utility of sequencing for AMR across all different areas, including the environment in animals and in humans. So do watch out for outputs from that working group, which I think are going to be very instrumental. And you can also go onto the Wellcome website if you want to have more information, because they're reporting in close to real time what their working groups are concluding. Next, I want to touch is wastewater and COVID-19. Now, on the left is a map in England showing the location of sewage treatment works that have been sampled for COVID-19 or SARS-CoV-2 during the pandemic. The shading indicates the weekly average SARS-CoV-2 RNA concentration, gene copies per litre. Now, if we think about the wastewater that's been sampled, it's got really a lot of advantages. It can be used at variable population scales. So it could be used, for example, at the outlet of a hospital, or it could be aggregated in, for example, a treatment plant. It has the advantage that it detects total burden of disease and doesn't rely on data only from diagnostics. It also reaches under-contacted populations. So again, a question: could this framework and the sampling be used to detect AMR? If it was, would the methods developed to detect variants be readily adapted for AMR? And what additional information could this provide? And finally, what AMR genes should be targeted? Now, I know there are discussions being held worldwide about how we can use wastewater for AMR detection and control, but this is very important for AMR surveillance looking ahead. Now, I want to touch on the point of integration of disciplines and data. When we went into the pandemic, many of the disciplines that are common scientific disciplines were very siloed. During the pandemic, what we've seen is an integration of these disciplines. And on the left, an image courtesy of Mark Caulfield, where we see a COG UK, the viral sequencing, coming together with genomic, which is the human sequencing, together with REACT, looking at mild and long COVID, combined with vaccines and trials, and the UK Immunology Consortium, the COVID-19 Immunology Consortium. Now, what can we learn from this for AMR? Now, the Outbreak Data Analysis Platform Partnership in the UK is actually responsible for joining together numerous data sets to see what we can learn from that and to try and aggregate the data, for example, to find out if we can understand better why some people die from COVID-19 and others don't. So back to AMR. What can we learn from this collaborative activity for AMR? We're still working in relative silos much of the time. And do we need to really rethink the way that AMR research is actually connected together? So really, could AMR research and control benefit from pandemic preparedness centres as well, where efforts are aggregated, or is something separate needed? So I'm really here thinking about how we integrate the way we work around AMR, learning from COVID-19. Now, my next slide will be rather obvious: COVID-19 and zoonoses. We know that COVID-19 occurred because of a virus spillover from an animal reservoir. And as a result, we are becoming increasingly aware of One Health interactions in terms that actually relate to how it impacts on individuals, on us, on the community. So could this be catalysed to better understand the role of animals in AMR? And what connections have we made during COVID-19 that should be preserved and strengthened? Now, I've covered 8 areas, and I've got another 9 on this slide. It's not comprehensive at all, but actually we've expanded our understanding of immunology and also structural biology, and those 2 disciplines have worked very closely together with virology and genome sequencing. We've also seen completely unprecedented pace of drug development for a control of SARS-CoV-2, or at least reduction of severity of symptoms in people who develop SARS-CoV-2 who are at risk of severe disease. There's been a huge sea change in infection prevention and control in our hospitals and in schools and elsewhere. Could we use that for AMR control? It was particularly telling that the amount of influenza we had following the pandemic and interventions actually plummeted. So what could we do to help with AMR? We've also thought about the wider environment. What about ventilation? What happens in schools, etc.? Importantly, behavioural sciences have really led from the front. They're the spearhead of action, and really thinking about hands, face and space. I test to protect you, you test to protect me. That kind of messaging. Could we really revamp our AMR messaging to be better at informing the public and getting control on the problem? Another area that's been very highlighted by the COVID-19 pandemic, unfortunately, is health inequalities and access to medicines. Now, this is true for AMR, and we really need to think about AMR in relation to health inequalities. We've also changed the way we make policy, and our public engagement has been extremely high. But I think, again, we could think about the narrative we use to describe AMR. Now, that's the end of the first section, and I'm going to go on now to think about the outcomes from a meeting that was held, a Forum Academy of Medical Sciences meeting in the UK, which was a collaboration between the Academy, the Department of Health and Social Care, and NIHR. Now, the title of this was Antimicrobial Resistance Research, Learning Lessons from the COVID-19 Pandemic. Now, there's a summary note already in the public domain, and the full report is coming out next week, I hope, when you'll be able to read in detail. The meeting was held in December. It started well before December, with an iterative process of refining what the workshop content should be. We only had half a day, and it was important that we didn't try to cover everything. I've already highlighted a large number of areas we could have tackled. Through iteration, we decided to focus on diagnostics and surveillance and therapeutics and vaccines. So apologies to those in the audience who have particular areas of interest outside of that, but I hope that you'll find our findings interesting. We had 2 questions. What lessons have been learned during the COVID-19 pandemic in relation to these 2 disciplines? And what are the next steps required to apply these lessons learned and new innovations to AMR? So looking back and really looking forward. Now, here's details around the meeting. We held a meeting for 3.5 hours where we had 2, I've already said we had 2 themes on diagnostics, surveillance and therapeutics and vaccines. And the way we ran this meeting was that we had 3 speakers at the beginning of each theme, and then a Q&A and a discussion. We then went on to have breakout sessions and then feedback. And then Professor Lucy Chappell gave us reflections on the topic. Now, looking at the meeting, it was there were 48 participants. It was a closed meeting, half of which were women. There was an equal spread across the different disciplines of diagnostics, surveillance, therapeutics, and vaccines, together with other areas of discipline. There were 4 public patient care representatives across cystic fibrosis, HIV, diabetes, and long COVID. And it was really important that we heard those voices from the public. In the bottom right-hand corner, you'll see the backgrounds of people. Most were from, the largest group was from academia and also from the public sector, but there was also representation from industry, from funding, from the regulators, etc. I'm going to discuss the findings or the outputs from that meeting in 3 groups. The first was a statement that diagnostics and surveillance will be a crucial aspect of the AMR response and can draw on the COVID-19 experience. There are going to be 5 points I make here. The first is that the testing infrastructure, which was developed for COVID-19, could be repurposed to support AMR surveillance. Now, certainly in the UK, some of our testing infrastructure is beginning to be quite dramatically reduced. But the question is, can we really think about our testing infrastructure, which could expand again to support our surveillance in AMR efforts? The second point that was made very strongly was that there needs to be engagement with industry and that needs to be much strengthened. It was considered that at the start of the pandemic, the engagement was not as strong as it needed to be. We also discussed regulatory pathways for diagnostics and that for the AMR space, these need to be reviewed. We talked about technological innovation and public adoption of testing, which are opening up new opportunities. And we also concluded that an end-to-end focus is needed for diagnostic development with multi-stakeholder engagement. Now, the second group of comments is really around the rapid development and approval of COVID-19 therapeutics and vaccines, and that there's also opportunities for AMR research. We talked about innovations in regulatory practice, and the MHRA have been outstanding in the UK, led by June Rain. They were crucial to the rapid but rigorous evaluation of COVID-19 vaccines and could be applied to AMR therapeutics. So a closer working relationship with our regulators could help us in the future. We also talked about capture and analysis of real-world and pragmatic trial data, which was crucial to inform COVID-19 care. This didn't take 5 years to do the study, write it up, get it peer-reviewed. Data was actually available much faster than that. Now, there are risks associated with that, but the speed at which data was available was very important to the response. And finally, we talked, of course, about innovations in vaccine technology, which could be a way to reduce antibiotic use. Now, the third group of comments are really about the fact that the COVID response was imaginative and characterized by a willingness to think outside of the box. And so, this was considered to be a unique teachable moment where radical new ideas could be considered, and they can be considered now as we go forward to address AMR as another public health crisis. So these are some of the possibilities we came up with. So an overarching national cross-sectoral research agenda could be developed. We also talked about the progress in antibiotic development and talked about an end-to-end public sector-based system to drive, which is driven by public health needs. Finally, we did talk about AMR being rebranded to capture political and public attention better, because without that, we will make no progress at all. So on to the last section of my talk, which is really about next steps to action. Now, this particular slide is really UK focused, and I'll go on to a global focus more in a minute. But the publication and wide dissemination of the Academy report, including to funders, I hope will have an impact in terms of people thinking about what actions they need to take. And the full report actually has a very long list of recommendations, or at least perhaps not recommendations, but observations that we could pick up on in order to take that forward. Now, the UK Department of Health and Social Care were part of that report, and their delivery board are reviewing the findings, and that would be crucial in terms of thinking about how the UK responds in research terms at the Department of Health level. Another possibility is the NIHR Clinical Research Network plans. They have a plan called the Antimicrobial Resistance Health and Care Collaborative, which is going to look at 3 areas. One is antimicrobial drug registries, which I'm also aware that other people are thinking about, patient-centered dosing. So not everybody needs the same dose of drug, but we're not really clear about how that would work and what impact that would have on AMR, and also trials to optimize antimicrobial treatment. In addition, individual action by funders and scientists is really key. So these are just some of the steps to action. Of course, there are many more to consider. Thinking about next steps for surveillance, and now I'm taking a global perspective, I think it is time to start to really bring together the idea of AMR surveillance using wastewater, environmental samples and clinical samples. We have been talking about this for probably more than a decade, but now is the time to really think about how we do that and to collaborate both across these different environments, but also across the different disciplines. Now, it's important to consider what the global pandemic radar could offer. This is a WHO hub in Berlin, which is particularly looking at pandemic and epidemic intelligence, but having actually developed so much sophistication and tracking, then surely AMR surveillance should be one of the beneficiaries. The reports that have been produced by the Global Pandemic Radar have little mention of AMR at the moment. And that's for us in the audience and for people elsewhere to be thinking about how the Global Pandemic Radar could really make a difference for AMR surveillance in collaboration with the WHO. Well, thank you very much for listening to my talk, and I look forward to taking your questions. Thank you.